Yes, 3, 2, 1, you can start now.
Good afternoon, everyone. It's a great pleasure to have you all here. I'm Dr. Omkaro, working as a medical advisor at Hetero Healthcare. Our topic of today's discussion is Experience Sharing Program on Managing PPH. The purpose of today's meeting is to have a better understanding of the postpartum hemorrhage and the role of carbetocin in it. Before commencing, I would like to introduce Hetero as an organization to you all. Hetero is serving in the healthcare industry since more than 25 years and has more than 300 products in its portfolio. It has 21,000 employees globally and is among the largest manufacturers of ARV, API, and FDF in the world. It has 36 state-of-the-art manufacturing facilities and has its presence in more than 126 countries. Hetero has Asia's largest API manufacturing facility at Visakhapatnam in Andhra Pradesh. The aims of Hetero include striving to fulfill unmet healthcare needs and reaching to customers across India. Hetero also has wide product range encompassing multiple specialties. It also has distinction of bringing 4 biosimilar products to market within 5 years of initiation. During the COVID-19 pandemic era, Hetero was pioneer in antivirals and offered oseltamivir, favipiravir, and remdesivir in its respective dosage forms. Now, I would like to introduce our speaker for today's meeting, that is Dr. Manisha Ranjan ma'am. Ma'am is currently working as a senior consultant and head of department at Motherhood Hospital, and she has also worked as a consultant surgeon at Nidan Hospital from November 2008 to March 2014. She has also worked as a senior resident at Rajwadi Hospital in Mumbai from November 2005 to October 2008. And she has also worked as a senior consultant at JP Hospital from 2016 to 2020. So with this, I welcome you, ma'am, and hand over the session to you.
Thank you so much, Hetero team, giving me the opportunity to talk on the very prominent that we gynae always care of. This is the postpartum hemorrhage. Thank you so much. Please share all the slides. So in postpartum hemorrhage, the blood loss of at least 500 ml following vaginal delivery and 1000 ml following C-section. This is the definition actually. PPH is a common and can occur even in women who are not at any risk. PPH is the leading cause of maternal mortality and morbidity in low socioeconomic countries and the primary cause of nearly 1/4 of all maternal death globally. So this is the some pictures. Maternal mortality. This is one of the leading cause of maternal mortality, accounting for about 35% of maternal death every year. Maternal mortality rate in developing countries was 240 per 10,000 live births compared to 16 in developed countries. So the mortality rate is very low in developed countries. Global PPH incidence is about 14 million women suffer from PPH. Incidence of PPH is reported as 2 to 4% after vaginal delivery and 6% after cesarean section. The incidence in India, 38% of maternal death are due to PPH. 25.7% of global death take place in India and 2/3 of these attribute to PPH. India has an unexpectedly high maternal death rate of 540 per 10,000 live births. So what are the etiology of postpartum hemorrhage? The tone, thrombin, trauma, tissue. Tone means uterine atony, inability of uterus to contract, which may lead to continuous bleeding. Any coagulopathy, failure in clotting. Any trauma like any uterine injury, vaginal injury, the injury in the cervical area. So any laceration or uterine inversion. Tissue, retention of placenta. Yeah. Retention of placenta and clot and abnormal placentation. Clinical finding in PPH. Abdominal tenderness, circulatory collapse, increasing abdominal girth, loss of uterine contraction, maternal tachycardia, and apparently we used to see the excessive vaginal bleeding. The clinical finding in PPH, degree of shock we have here described: compensated, mild, moderate, and severe shock. Blood loss about 500 to 1000. This is compensation, 10 to 15% it happens. In mild shock, the loss is about 10,000 to 1500. In moderate, the loss is about 1500 to 2000 milliliter. And in severe shock, the loss is between 2000 to 3000 milliliter. The blood pressure in compensation, there is no fall in blood pressure. In mild shock, there is slight fall in blood pressure. The systolic and the diastolic 80 to 100 goes down. In moderate shock, the BP fall more. 80 to 70 to 80 is the systolic. And in severe shock, there is profound fall of blood pressure, 50 to 70 millimeter of mercury. The symptom and sign of PPH in mild, in compensated, mild palpitation, dizziness, and mild tachycardia. In mild, sweating is there along with weakness and tachycardia. In moderate shock, there is restlessness, there is pallor, there is oliguria, and in severe shock, there is collapse and air hunger with anuria. Approach towards postpartum hemorrhage. Poor uterine tone. So how we will check the uterine tone is poor? The clinical finding, if we are doing the perabdomen examination, uterus is flabby, relaxed, boggy, and soft. If we palpate the fundus may be felt above the umbilicus if the uterine cavity is filled with blood and blood clots. Investigation, if we are doing, we used to send CBC coagulation profile and serum electrolyte with blood urea. If patient is not responsive to fluid and the blood replacement is important, ultrasound can be done that time to exclude any uterine rupture or intraperitoneal bleeding. Management for these type of poor uterine tonnage, uterotonic agent like oxytocins, prostaglandin, ergoid, alkaloid, uterine balloon tamponade can be used. Hemostasis. See, main stepwise surgical manuals are there. First, we go for the medical management, then the surgical management, and finally, we used to decide further intervention. Nowadays, we do some radiological intervention, and if not getting recovered from any of things, then the finally, depending upon the type of shock, we used to go for hysterectomy. That is the last thing. If this postpartum hemorrhage is cause of trauma, the clinical finding is the bleeding from the area of trauma or the genital tract. If it is uterine rupture, on the ultrasound, we used to see inside the intraperitoneal collection is there, extension of uterine angle when we are doing the cesarean section, tears during cesarean section, extragenital causes such as subcapsular live rupture or rupture of ovarian or splenic vessels. This is very rare, but sometimes it does happen. Investigation, inspection during cesarean section by exteriorization of the uterus, and all ultrasound can help to identify whether any intraperitoneal collection and the collection is coming from which area. Management, repair of identified genital tract trauma, if it is from outside from the vagina or the cervix, if any laceration or any vaginal trauma is there or any cervical trauma, we can repair that area. Pelvic and arterial embolization, that nowadays we used to do. We have a very good radiological management. We have a good radiologist, and by their help, you can go for uterine artery embolization. Retained tissue, in clinical finding, we see the retained placenta and the membranes, identify during bimanual examination under anesthesia, and management is removal of retained product of conception or placenta under general anesthesia. If it is because of coagulopathy, clinical finding, we used to see continuous bleeding, uterus is well contracted, even the bleeding is not getting not getting decreased, then we send some investigation, CBC, coagulation profile. Uh, we used to see serum electrolyte and and the urea. Management is medical, immediate replacement of blood and blood product platelets, on surgical only with trauma or atonic hemorrhage, unresponsive to medical management. So the next slide. Rationale for development of carbetocin in new heat stable formulation. Carbetocin is available in a room temperature stable formulation and convenient vial presentation. Oxytocin and ergot alkaloids should be kept in a refrigerator to avoid degradation. Heat stable formulation of oxytocin is currently not available. Previous formulation of carbetocin should be stored between 2 to 8 degrees Celsius. Resource poor countries do not always have cold chain transport and storage capabilities. So need for refrigeration, carbetocin and ergot alkaloid like methazine need refrigeration. But in carbetocin, it is stable at room temperature, has shelf life of 24 months at 30 degree and 75% it requires the humidity. Avoid need for cold chain storage and logistic is provided in a vial. Use of uterotonic agent. So molecules are oxytocin, carbetocin, ergometrin, symptometrin that contains 500 mcg of ergometrin and 5 unit of oxytocin, misoprostol. Time of administration at the crowning of baby head, at the delivery of anterior soldier, at the end of second stage of labor following the delivery of placenta. Prophylaxis, prophylactic use, prevention of PPH and active management of third stage of labor. Therapeutic use, management of postpartum hemorrhage. Carbetocin was created by making several modifications to the oxytocin structure. It has a prolonged half-life, reduces enzymatic degradation. Next slide.
You want next slide, ma'am? Yeah, please.
So efficacy and safety of carbetocin versus oxytocin. Carbetocin non-inferior to oxytocin, and WHO champion trial has been taken on that. Carbetocin decreases the need for uterotonic agent versus oxytocin. Single dose carbetocin versus continuous infusion of oxytocin. Comparison between the carbetocin versus oxytocin with respect to reduction in blood loss and need for other intervention. Efficacy and safety of carbetocin versus symptometrin. Efficacy and safety of carbetocin versus misoprostol plus oxytocin. So oxytocin is a synthetic cyclic peptide form of naturally occurring posterior pituitary hormone, binds to oxytocin receptor in the uterine myometrium, stimulating contraction of uterine smooth muscle by increasing the sodium permeability of uterine myofibrils. Intravenous, almost immediate action with peak concentration after 30 minutes. Intramuscular, slower onset of action, taking 3 to 7 minutes, but produces a longer lasting clinical effect of up to 60 minutes. Half-life is 1 to 6 minutes. Requires protection from light and storage at 2 to 8 degree continuously to preserve its activity. So it is used in induction of labor, augmentation of labor, prevention of PPH, and treatment of PPH. So carbetocin is again long-acting synthetic analog of oxytocin and agonist property, binds to oxytocin receptor in the uterine smooth muscle, resulting in rhythmical contraction, increased frequency of existing contraction, and increased uterine tone. It can be given intravenous, sustained uterine contraction within 2 minutes, lasting for about 6 minutes and followed by a rhythmic contraction for at least 60 minutes. It can be used IM also, sustained uterine contraction lasting for about 11 minutes and rhythmic contraction for 120 minutes. Half life is about 40 minutes. Storage can be stored up to 30 degree. So it is not used for the induction of labor, neither it is used for augmentation or prevention of, yes, used in prevention of PPH, not for the treatment of PPH. So we use this as a prophylaxis, not for the treatment. Carbetocin non-inferior to oxytocin, WHO champion trial. This trial says the largest clinical trial in the prevention of PPH. Study design, non-inferiority, double-blind randomized trial. The objective was to compare the effectiveness and safety of investigation heat-stable carbetocin to oxytocin in the prevention of PPH after vaginal birth. Patient enrolled 30,000 women across 10 countries, including India. Primary outcome, the proportion of women with blood loss of at least 500 ml or the use of additional uterotonic agent. The proportion of women with blood loss of at least 1000 ml. Carbetocin non-inferior to oxytocin. The trial was parameters are blood loss of more than 500 ml or use of additional uterotonics. Carbetocin, the efficacy was 14.5, oxytocin 14.4. These are the comparison studies that we used to do on carbetocin and oxytocin. There is no anticipated air embolism. The frequency of expected AIs did not differ significantly between these two groups. So conclusion was carbetocin was non-inferior to oxytocin for the prevention of blood loss of at least 500 ml or the use of additional uterotonic. Cochrane review, carbetocin for preventing postpartum hemorrhage. In this Cochrane review, data from 11 studies involving 2635 women were included. The author concluded that for women who undergo a cesarean section, carbetocin resulted in statistically significant reduction in need for therapeutic uterotonics compared to oxytocin. Also, carbetocin is associated with less blood loss compared to symptometrin in the prevention of PPH for women who have vaginal delivery and is associated with significantly fewer adverse effects. Guideline recognize the benefit of carbetocin for preventing the uterine atony. Recommending bodies was WHO, SGO, GC, these New Zealand Society, FIGO Germany, Australia Swiss body, FCOG France Society. One of the following guidelines for PPH prophylaxis, the oxytocin, carbetocin, misoprostol, ergometrin, oxytocin and ergometrin fixed dose combination. Uh, Canada shows carbetocin 100 microgram IV bolus. Active management of third stage of labor, prophylactic uterotonic. Carbetocin, one of the recommendation for PPH by FIGO Society. Germany, Austria, Swiss body also suggestive carbetocin 100 micrograms slowly IV. FIGO, FCGOC, France Society also suggests carbetocin on providing non-inferiority to oxytocin. My experience with carbetocin, the
Yeah.
smartest, superior, and safer choice for the management of PPH. In my opinion, also, I'm working in this OBGY since 20 years. So recently, 5 years, I'm using this Carbetocin for the prophylaxis, and I'm very much satisfied. It's more quicker. The action is, feel that the field is totally bloodless when we are giving the Carbetocin instead of routine oxytocin, right? So for prophylaxis, we are using Carbetocin since 5 years, and I'm very happy and satisfied. Nowadays, we are not using methazine for the prophylaxis. We are not using any prostaglandin for the prophylaxis. We are using only the Carbetocin, and the second line is oxytocin. Third is
Okay. Oh,
tranexamic.
okay. Means, as you said, ma'am, efficacy-wise, it has really proven to be superior, we can say, to other
Right,
uteroderms.
right,
And
right.
safety-wise, ma'am, if you have to add certain comments regarding safety of carbetocin in your experience.
So I'm using in all my patient nowadays in urban area. We used to get all the high risk patient, but I don't think I have ever counted any adverse effect till now. So there is no water retention. This is one of the great feature of this Carbetocin. We are not getting any water retention that we used to get in oxytocin.
Okay, okay. Yes, thank you, ma'am, for sharing your experience. Now we move forward to the next part of our session, that is panel discussion, where we'll be having some frequently asked questions and real-world scenarios. So, ma'am, considering the incidence of PPH in India, so the incidence of PPH is observed to be a bit on higher side. So, what are the factors or reasons, ma'am, we can say because of which the PPH is considerably more in India?
Age, if patient is young or patient is elderly. Second, over distended uterus if they are carrying more than one pregnancy or the baby weight is on higher side, or patient with polyhydramnios, the amniotic fluid is on higher side. Patient previously suffering from some high risk factor like preeclampsia, pregnancy induced hypertension, gestational hypertension, or mother is elderly with diabetes, right? Any coagulopathy, she is suffering with any coagulopathy. So these are the things that increases the chances of PPH.
Okay, okay. Means we can also say that the prevalence of these conditions is also more in India, because of which again the prevalence of
Yeah,
PPH
most
is
of
more.
us, the women here in India is mostly anemic, and we
Okay,
are not
okay,
building up the iron.
okay. Yes, yes. Okay. So, moving to the next question, ma'am. So, what are the patient profiles where doctor can anticipate PPH, a particular patients where there are high chances of PPH? Means you have already spoken on this in the last
Yeah,
question. Any?
whatever the etiology, we have to just take care whether the patient is elderly, whether the patient is very young. In urban area, we used to get the elderly patient. We used to see whether the what's the BMI of the patient. If the patient is very obese, the BMI, she is morbidly obese, she is having some previously some metabolic disorder like hypertension or diabetes, the chances is high. A patient with IVF conception, patient with multiple gestation, patient with polyhydramnias, right? So these are the chances of PPH is very high. So we have to keep
Okay, okay.
ourselves very ready for to prevent the incidence.
Okay, okay. Yes, thank you, ma'am. So, moving to the next question. So, you already commented that, ma'am, in India, the prevalence of anemia is more. So, then again, is anemia considered a serious risk factor for PPH, particularly in India, if we say?
Yes, in rural area, yes, because people doesn't seek at right time the health system. They are not, and the compliance is very low taking the iron capsule. But in urban area, because we do the rigorous antepartum antenatal care, so here the incidence is low. Here the incidence of anemia during antenatal period is low. But yes, in rural area or tier two cities also the incidence is high because of not reaching to the obstetrician and not maintaining the compliance.
Okay, okay. Yes. Thank you, ma'am. So, which drugs, ma'am, do you generally use, and your drug of choice or preference for prophylaxis of PPH?
So, in my hospital, I was at Motherhood, and now I am at Cloud9, heading the team at Cloud9. So, for prophylaxis, we are using carbetocin in most of the patient. Second is the oxytocin and the tranexamic acid.
Okay, yes. So moving to the next question, ma'am. Considering the use of carbetocin for prophylaxis, so do you use it in high risk patient or all the patients for prophylaxis?
All the patient for prophylaxis.
And if you have to tell the reason for it, ma'am, means just any additional comments on that?
So it's written previously. Also, we talked on. We don't require any cold chain. So
Yes.
and
Okay.
it's very easy to maintain the environment, right? So and we are not infusing. It's a single dose. We are not giving extra 20 units bolus or 15 units or 10 units. So we are one single injection, and it's convenient for the anesthesia people also to give this injection. So
Okay.
easy
Okay.
maintenance, and the cold chain we are not maintaining. So for us, it's very easy.
The convenience of mode of transport and mode of administration for
Right.
both, we can say. Yes.
Right.
Okay. So, ma'am, as route of administration, if we say IV route is the preferred one, are there any case scenarios or patient profiles where IM route would be preferable and would be the choice?
So mostly we used to give IV route. Rarely we give IM route. This is a anesthesia wala mostly used to do. They are sitting on that side. So IV route is more preferable. I haven't used IM.
Okay. Thank you, ma'am. So, moving to the next question. So, after the use of carbetocin, ma'am, what is the prevalence or frequency do you observe for PPH?
So mostly uterus tone get totally established after giving within 5 minutes. So we don't require the second drug. But yes, in some cases, if it happens, we use the second line like misoprostol or methadone instead of
Okay.
using oxytocin.
Okay, means we can say that in almost all of the patients after the use of carbetocin, we don't see the incidence of PPH because
Rarely we require.
yes. So, ma'am, even if PPH occurs in spite of using carbetocin for prophylaxis of PPH, do you feel in such cases there could be reduction in the intensity of PPH?
Yes,
Yes. Means either it will prevent or it will reduce the intensity of it.
right.
Okay. So, ma'am, you have already spoken on it. What are the advantages of using carbetocin over other uterotonics for the prevention of PPH? And if we have to differentiate between its use in metro cities, for example, and cities in periphery, is there any distinction or is it just the same?
No. See, carbetocin is very safe drug like oxytocin. We cannot use methadone in all patients. Nowadays, it's not in the prevention of PPH. It's comes in the management of PPH because it has multiple side effects. We cannot use in anemic patient. We cannot use in patient with heart disease. Same way, the misoprostol or the prostaglandin, we have to, some restriction while using all these drugs. But carbetocin is safest. There's no other effect. Instead of if we are using oxytocin, the water retention is high. This is better than the oxytocin. So our preferred choice for the prophylaxis is carbetocin.
Okay, yes, thank you, ma'am. So you have already spoken on the safety of carbetocin. Any additional comments regarding its safety and tolerability in patients, ma'am?
I don't think oxytocin may cause nausea. Sometimes patient just vomit. There's sudden hypotension that we don't encounter in carbetocin.
Okay, means both hypotension as well as GI disturbances, the prevalence of it we observed it to be less.
Right.
Yeah. Yes. So, ma'am, what is the benefit of using carbetocin as a first-line drug to prevent PPH in every patient and every delivery? So you have already spoken on both the efficacy and safety of.
Yeah, we have answered on this question prior also. It's easily available, very less maintenance, no maintenance, we can say. And the single drug is more than sufficient.
Hello, ma'am.
Hello.
Yeah, yes, you're audible, ma'am. Yes.
So easily available, no, maintenance. We can keep it normal temperature, and single
Okay.
dose is more than sufficient.
Okay. Okay. Yes. Thank
We
you,
don't
ma'am.
require multiple doses.
So moving to the last question, ma'am, if you have to summarize your entire experience of using carbetocin, be its safety or efficacy, or its route of administration, if we have to say, and to our delegates, if you have to add any final comments, what would it be?
So yes, everyone, please use carbetocin. This is very easy, very safe, very less. The side effect. The best is there is no hypertension, so patient may start vomiting after using the oxytocin. So this is very easily, administered drug to prevent the PPH as a prophylaxis. Thank you so much. Thank you so much to giving me this opportunity.
Yes, yes, okay, yes. So, thank you so much, ma'am, for sharing your valuable insights and guiding all of us regarding the use of carbetocin in patients. And thank you for sharing the cases as well. So, this brings us to end of our meeting. So, I would like to also
मैम को पेशेंट्स आए हुए हैं इसलिए